And okay, so thanks everybody for joining us. You're here for the Long-Term Services and Supports Information Sharing webinar. And I'd like to go ahead and I'll let our presenter, Dwayne Mays, say hi and start off.
Well, it is now afternoon, so good afternoon, everybody. This is Dwayne Mays, and I'm the director for the Division of Senior and Disability Services. We have our chiefs, all three of our chiefs in the building, and so they'll be in and out, and when they come into this office, we will announce that they're here, and they may be a part of this presentation. But today's presentation will primarily be offered up by myself and Kara. So just a couple of sound bites regarding the week. We did do this same webinar, the webinar that we're doing with you right now. We actually had a forum Wednesday evening at the Special Olympics building here in Anchorage from 6 to 8. And of course, our focus was to try to reach out and engage the recipients that are actually receiving services, as well as family members of recipients that are receiving services. And so we had a full house at the Special Olympics building, and I think we were there to probably 8:45 that evening. So it was well attended, and we had a very robust and rich dialogue between the state and between families and recipients. So that's a good thing. And so this presentation, as it says on this slide, is about long-term services and supports, LTSS. This really has to do with the Medicaid reform that the state is going through, and this all started 2 sessions ago. And then there was a bill that passed, Senate Bill 74, sponsored primarily, the primary sponsor of that was Senator Kelly, who today is the Senate President. So he sponsored that bill, and there were 16 initiatives within that bill. One had to do with the presentation that we're about to do today, all about reform efforts specific to LTSS within senior and disability services. So with that, we will move on to the next slide.
Okay, thank you, Dwayne. So this is Kara again. Just going to start us off here with some introductory thoughts. Some of us may have participated in previous webinars to introduce new thoughts and pathways and things like that. So we are going to broadly be talking about these things in the beginning, and then we'll get to more specifics in a little bit. So I'd like to talk about, or we would like to talk about, what came before these changes that we're going to introduce, things that are happening soon, new choices and new words, working in the world of services. There's lots of different initials that we use and overarching descriptive words that we use that that mean certain things. So we have a new term coming in, and we just want to be sure that people understand what that is. So there'll be new choices coming in terms of services with acronyms that go with them, and of course your questions and comments. Before we get to that, though, I would like to talk a little bit about what are the ideas behind all these changes. It's related to what came before them, and I like to give a little bit of context so that people understand these concepts for changes. Whenever we have changes to long-term services and supports or home and community-based services and things like that, there's always legislation attached to them. This just means that there's laws attached, and with laws, laws are made to be responsive to, they are made in context of response from people who are affected by them, meaning Alaskan citizens. So that is something to think about with working with concepts ahead of time. Being person-centered is a big part of what we're talking about here. So we're going to talk about that first. The meaning and the intent of changes comes first. So being person-centered It means that you decide what works for you. People who get services make decisions in ways that work for them. The idea behind the presentations is so that you can get more information and learn, think about what changes mean. The actual laws and regulations are not finished yet. You can make an informed input to them, but the presentation isn't meant to change anybody's mind. It's to give information so that you can take your stance for what it means to you. Alaskans can certainly take part by commenting on laws. There's different ways to do that. If you want to learn more about that, you can always email us, or we've got other ways that you can learn about it too. Care coordinators can help with those things too and give people direction. Mostly what we have here in the concept, the biggest change is the introduction of a new acronym, LTSS, Long-Term Services and Supports. It seems like not a big change, but it is kind of a big change. The bigger story behind the words long-term services and supports is that it really is trying to convey that it means help that you need so you can live your life, rather than just care. People experiencing disability, getting supports to live life, rather than the mind frame of applying care towards every aspect of your life. And so that is why I'm showing it like this: support so you can live your life, so you can rock your life.
So when you look at this slide, just go to the bottom left where it says long-term services and supports. I'll first start with just a personal comment that often when I'm socializing with my friends or I'm having conversation with my brother or sister, they will ask me, what is it that you do? And if I really get into the nuts and bolts of what I do, I know that I lose my family in the minutia. I know that I lose my friends to it. And so if you were to circle back with them and ask them, what does Dwayne do as a division director, they wouldn't be able to articulate it because it's complicated. And so I always come forward with, it's all about long-term support services, and it's supporting people either within the community, in a community-based setting, within their home, and I'll break that down a little bit, as well as, under the LTSS umbrella, it could also mean nursing home care, and we do that. So when you look at this slide, if you move up to the top left corner, home and community-based supports, there are different pieces we have within our division that address that. We have the home and community-based services waivers. We have 4 waivers currently within SDS, and it supports our vulnerable populations that meet eligibility to remain within their community in a very natural environment. So we have that. Personal care services, which is a Medicaid state plan option. We've had that program now for several years, and it supports people within their home in terms of maybe their inability to take care of themselves and they need a little bit of assistance. So we have somebody coming into the home to provide that care. So we have a personal care program. Then we have state-funded services. We are thinking about a name change specific to the approximately $40 million that we put out in grants, some of that being senior grants, some of that being BD grants or other types of grants. And so there's been some discussions internally of calling it community-based grants because that's just an easier way to handle that. Within that community-based grant world of 40 million, some of those components, whether it's adult day services or senior in-home services, is pure general fund programs. And that's really important to know in terms of the reform efforts that we're going through. It's pure general fund programs. So, and then the other piece that we have at the bottom right of this slide is that I think people don't know this, but we are the division that authorizes payment for nursing home care for those individuals that meet eligibility. We have, I think, 16 nursing homes around the state and about a 992 bed count the last time I talked to our people in the research and analysis unit. So we do that. We do about 120 million in authorizations a year for nursing homes. And we know that there are new nursing homes going to be popping up in the Mat-Su Valley. So that is a part of that continuum of care. Okay. So I think, you know, when we talk about, and I think this slide, I'm going to have Kara and I kind of do a on this one, but person-centered, you know, with the settings rule that has come down from the feds mandating that for existing home and community-based waiver programs, we're going to have to provide evidence to the Center for Medicare and Medicaid Services that we meet the settings rule. And a part of that is all about being person-centered. And I'd like to, you know, I was one to admit that we are a very person-centered state. But in doing our due diligence and going out and making sure that all settings are truly compliant and meet that definition, we have been able to peel away at some of that and realize that we are not really completely a person-centered state. So we have a little bit of work to do. We've done quite a bit of outreach to the provider organizations, to the advocacy organizations about this very issue. And I think now people recognize that we have a little bit of work to do to become truly person-centered. Who drives the development of the plan? It's the recipient. And I think there are some providers that kind of drove that because they're thinking about the bottom dollar for their nonprofits. And so I understand that and I respect that. We have to get back to truly making sure that the recipient drives the development of that plan. What is it that they truly need?
Okay.
You want to add anything to that?
Absolutely. The way to think about it is that the person, it's not just person-centered plans, it's person-centered services. So ongoing, a person should be able to see and realize the outcomes that they want to have happen in their life. A person may achieve outcomes or may do things that they want to do with the help of services, but not only services, because a person has many things, you know, many parts of their life, and so it's so individual that being person-centered really just comes down to the person themselves. The help is help that works with what you can do, moving towards a strengths-based approach, thinking about things like measuring progress as opposed to developmental markers and things that are kind of more from the previous context. And I'm talking broadly, you know, it's taken years to get to this point for many services and other states too. But this is the way that it is going for all of states that are participating in these home and community-based, you know, realms and LTSS realms. And so it's about you tell how you want services to help you, and you lead the team.
So this slide has to do with, so what is happening soon? And we're going to get into the mechanics of what is happening and kind of where we're going. We recognize and know that now more than ever, we have more people in Alaska that need help going into the future. I don't think it's a surprise to anybody that the state now for several years has been in a fiscal crisis. So we have a significant budget deficit that we have to attend to from year to year. And so over the last couple of years, we have taken some slight reductions. And we've fared pretty well in comparison to other divisions within the department. We've done really well to advocate for these programs and services. And I think both sides of the aisle understand that. And so I think from that perspective, that's a good thing. But the senior population continues to grow. We're the fastest aging state in the country, and you've heard that probably in several forums. The number of people that we are serving that have disabilities continues to go up, but we're unable to really grow our budgets. Either we take a slight reduction or it's been flat now for several years. And so more people need help. And how do we do that given the circumstances where we're at? We all know that there really isn't anything that we're aware of right now in front of us that's going to generate additional revenue. And I've been very frank and upfront in my presentations that, in I think a week or two, we're going into special session. And our governor has directed the legislature to come up with a revenue package to pay for government. And so that's happening. And so maybe there will be some hope that something will occur after the session is over with, and then we can move on. It may not happen, and then we're going to enter into another session where we're going to have to try to find ways to be lean and mean, which is really our motto for the last 3 or 4 years. So we know more people in Alaska need help now and will into the future, and we have to do something about it. So, budget reductions. Alaska has less money to pay for the help that more people need. And so that's in front of us. We've taken some slight hits specific to that, and so we're trying to attend to it. And I know that it makes for a very stressful time, especially when it comes to attending to and communicating with our recipients and families. So we know that our dollar is shrinking here in the state of Alaska. Okay, so Alaska has less money to pay for the help that more people need. And so you see these 4 boxes. And by the way, I love this PowerPoint, and Kara actually developed it. I think she's very innovative. If it was me, it would just be very black and white, but I always appreciate having Kara develop these because it really flows. So there are 4 boxes there on the screen. The box to the left that says CMS, the Center for Medicare and Medicaid Services. At the very top, it says offers to help that Medicaid pays a part of instead of only Alaska funds. So when we look at that, we think of, and this is where I mentioned before, looking at the landscape of our funding as a division, we have components within our budget that are pure general fund components. For example, Community and Developmental Disability Grant funding. That's a pure general fund program. And we spend GF of about $12 million a year specific to that component. So with CMS and all these different Medicaid authorities and options in the reform efforts, we want to take some of our general fund programs and refinance that under a Medicaid option so that we can draw down a 50% federal match. The second box, where it says budget, restructure to work within the budget, make sure people can still get the help. So we know what the realities are of our budget. So, for example, with these general fund programs, what we're saying to the legislature, we get that we're in a fiscal crisis. So instead of sitting back and taking hits year after year, we want to be proactive and work with the legislature to take our general fund components and refinance that under a Medicaid option or authority. Then we can return half of those general fund dollars back to the state. It's our way of saying we understand the crisis, but at the same time bringing in additional federal dollars. So the budget realities are really, we're faced with trying to be much more innovative and doing what we can to bring in additional dollars from the feds. So people, director, supports, and dollars is the third box here. And I love the rock your life comment. But there is evidence that if you are truly person-centered, and it's the individual that's driving the development of the plan. As a general rule, they're going to be very responsible in what that plan will look like. And we're confident that as we work to be 100% person-centered, that we're going to see efficiencies and reductions as a result of that. So it's making sure that we are paying for what is considered true need for those individuals. And it really reinforces our motto that getting the right amount of services to the right people at the right time. So we really believe in that. And then, of course, with all of that is our ability, within SDS, we're creating some new system enhancements, a new data management system. Doing all of that really helps us to better track, and through this very person-centered way, helps us to track whether or not we're making a difference and what changes can we make in the future based on the data that we're gathering to make those improvements. So one of the things that I try real hard to do is to make sure that we have done a really good job of engaging our communities. And through the reform efforts, because one of the authorities that we identified that we would consider, which is the 1915K, that's just a section within the Social Security Act. It's another term that we use is the community for choice option. We were, as a part of Senate Bill 74, directed to pursue consideration of 1915K. Well, that requires that CMS wants us to create a council of recipients and or family members of recipients that we can then formally engage as we go through the process of exploring, designing, and actually implementing the 1915K. And so we created the ICC, the Inclusive Community Choices Council. And so we have formalized meetings on a monthly basis, and we have ongoing and dialogue between those members as well as the state staff. In addition to the ICC, we've actually added advocacy organizations and provider organizations to be a part of that. That said, we always prioritize the recipients and the family members to make sure their voice is heard first. And I think we've done a good job with that. So the 1915K requires us to have a council in place. So just remember that. And then just a little bit more where it says, as I mentioned in the previous slide, we broke it out into two pieces. The inclusive community choices, and then it says here P to the left, those are the participants, the recipients, the individuals that we really want to make sure are heard. And so in the description there, it says people enrolled in LTSS in Alaska and their advocates who are also not providers. Disability groups represented on the council include intellectual and developmental disabilities. So I think this is important to remember. So who's on the council? Intellectual and developmental disabilities, people with physical disabilities, those with severe mental illness. We have a couple seniors on our council, and then children with special health care needs, as well as those with traumatic and acquired brain injury. And so that piece of the council has to do with actual participants, recipients that are getting services, or family members. The other, to the right of this slide, it says ICCOS, other stakeholders, and that would be all the different associations from the Alaska Association of Developmental Disabilities, the Alaska Behavioral Health Association, we have the Alaska Native Tribal Health Consortium as a part of that, the Alaska State Hospital and Nursing Home Association, and the Community Care Coalition. So we believe that we have great representation on the ICC of all those associations that have something to do with our world. So let's talk about what these new choices and new words are. So let's get into the meat of that. Okay. So the Individualized Supports Waiver. So before we start filling in those 6 colored sections, when the bill, Senate Bill 74, passed 2 sessions ago, giving us the authority to explore the 1915I and 1915K options, the end result of that effort with a contractor that we hired to explore those options confirmed that and concluded that we would move forward with the 1915K, the Community First Choice option. So that's a done deal. We're moving forward with that, and we continue to communicate with the ICC regarding our progress around the Community First Choice 1915K option. The 1915I option, we did our due diligence. We explored that option, and we targeted 4 populations under the I option, those with IDD, those individuals with SMI, severe mental illness, those individuals with ADRD, Alzheimer's disease and related dementia, and those with traumatic brain injury. In our effort to use that to refinance any general fund program within our world, we did quite a bit of reconfiguring. We would break down a basic service package, and in the end, we realized that even with all that work, we would be growing the budget. We would not hold the line specific to those general fund programs that we would refinance. So the conclusion and recommendation that came from the contractor was that we now pursue the 1915I. Remember, you can't cap the 1915I. So from a state perspective, that's one way you can control, but you can't do that. And it's an entitlement program. So it would be opening the floodgates, if you will, and we'd have a hard time managing that. And that's really not the intent. So the contractor made the recommendation that we look at another waiver under the 1915C section to the Social Security Act. If you remember, we have 4. Currently, we have 4 waivers. And at the time they made that recommendation, they referred to it as the Limited Supports Waiver. So with that recommendation, there are 2 key components to remember in this presentation. One is that you can cap. So with another contractor and communicating with the Center for Medicare and Medicaid Services, we knew that we could establish a cap. And the second is that we could create a wait list. Those 2 components alone will help us to control costs. And so that's key to this. Now, over time, I think internally, along with the ICC, the word limited has a negative connotation. So we made a decision to change it to individualized. So now we refer to it as the Individualized Supports Waiver. So with that, let's pull up the next piece here. So many people are asking, so what's the eligibility? To put it simply, it's the same as the IDD waiver. You must meet ICF IDD, intermediate care institutions or facilities for those with developmental disabilities. That's a mouthful. So I always use, quite simply, institutional level of care. And so the eligibility for the current IDD waiver would be the same for the ISW waiver. So that's important to know. So with us looking at our budget and looking at, and we'll get to this in a second, the service array of the package of services that we would offer under the ISW, we have concluded that the cap to the ISW will be $17,500 a year total. So a person can decide how to use those services up to that total amount. So $17,500 will be the cap for the ISW. And this is a big question because we had a few care coordinators at our community forum on Wednesday evening, and so when they saw this, I think that answered a big question that they brought forward, which is care coordinator is a must, but not included in the amount. So care coordinator work will be different than the IDD waiver. When I say that, the intensity and the level of effort that the care coordinator puts into the IDD waiver will not be the same for the ISW. And so I think there were some care coordinators who were kind of disappointed, which kind of reminds me then that, are we really a truly person-centered world? Or are we worried about costs and how much am I going to make? So care coordinators will not make the same level of money that they do on the IDD waiver. And what's important to remember is that the cost for the care coordinator under the ISW is outside of the 17.5 cap. So we're not just going to sit back, develop this, make it look nice and pretty, have all these colors and really beautiful graphics, and we get approval from CMS, we're ready to go, we got regulations, and then we just flip the switch. It will blow up our division, and we wouldn't be able to handle the level of assessments, initial assessments that we have to do. So we're sending out letters, and so to date, we have sent out close to 220 letters to recipients that are currently receiving grants. And so we're staggering this, and we have a little over 600 individuals that are currently receiving grants. So from month to month, the IDD unit, where the ISW will be parked, is doing that. So we're staggering it just to kind of ease into this. And we know that in doing so, letters will trigger questions and anxiety and what's happening to my grant dollars for this particular person. And we had a lot of that dialogue at the forum on Wednesday evening. So we have done webinars, and we will do more communication with our community to make sure that we kind of ease the burden sliding into this new waiver. So it's for certain services only. So most services like the IDD waiver, but there's except out-of-home residential. So that's the exception to the rule. So the majority of services that one receives through the IDD waiver will also be offered under the ISW waiver. So that's just important to note that. And then, of course, here where it says services, and for many of you online, respite, supported living, intensive active treatment, non-medical transportation, etc. So there's that service package that we will offer under the ISW.
Okay. And this is Kara. Do we want to do any questions about this now, or wait until we're done the whole presentation for questions?
And so Kara's asking me that question, and I'll go ahead and answer. I would prefer that we get through this because I'm confident we'll be done in probably the next 10 to 15 minutes, leaving us with well over an hour. And so if you have a question right now, just write it down so you don't forget it. So let's get through I find that if we break up the PowerPoint and then take questions, we might be still answering questions by the time it's 2 o'clock. So just remember, so the reform efforts for SDS under this bill, ISW, and we just went through that, to refinance the Community and Developmental Disability Grant, $12 million of general funds that we spend from year to year. Half of that now will be replaced with federal dollars. So it's now going to become a Medicaid option, or I should say a Medicaid authority, not an option, excuse me. The other, as I mentioned in my presentation, the other is really actually an option referred to as community first choice. And so I've mentioned that. That's 1915K. So it says here, nursing facility level of care. So again, just using simply, put it simply, institutional level of care. You must meet nursing facility level of care to get into the community first choice. The current PCS, Personal Care Services Program, does not have the same eligibility requirements that we have for our 4 waivers, or this. So there is a difference between PCS and community first choice. Intermediate care facilities for individuals with intellectual and developmental disabilities. institution for mental disease for participants age 65 and older in terms of level of care. Institutions providing psychiatric services for individuals under 21 level of care. So that's the eligibility requirement for CFC, Community First Choice option. The intent with CFC is to help people who need personal care services and that they meet that level of care that we just talked about. What's unique to the Community First Choice option is that we're able to get an additional 6% federal match from the federal government. So instead of what we have right now with PCS services, dollar for dollar, 50-50, we would be able to draw down a 56% match from the federal government. So that gives us more money coming in. Remember, Community First Choice is not a waiver.
Right, and this is Kara, if I could just jump in really quick. I'm learning about these options too as we go. This slide shows the structure of Community First Choice. I did get a lot of questions about the populations that it could potentially serve, and what would that look like, and would this be people who SDS is already serving, or is it for people who have needs that could be met by other divisions, programs, for example, behavioral health? So my best answer is that this is the eligibility doorway for this choice should a state implement it. If the people that we serve have reached level of care under nursing facility level of care, they could come in through the SDS door. They may experience other conditions that would qualify them, or other circumstances that would qualify them for the other ones that you see, and kind of a blend too. But we're developing partnerships to help meet needs through programs that might not be held at SDS, if that makes sense. So it's a new thing, and it's a new best thought of right now as enhanced PCS, like PCS, but enhanced PCS. So in that sense, it's not a waiver. It's through it's through Medicaid, but it's not considered a waiver. It's considered most like PCS. Okay.
Okay. So with just to give you something, and this is not up here on the slide, but these might be some relatively old numbers, but under the current PCS program, Personal Care Services, for which we spend about, in last year, I think we spent about $70 million to serve over 4,000 individuals. Of that 4,000, and it might be different today slightly, about 1,600 or so individuals meet nursing facility level of care or ICF-IDD level of care. So we would take the 1,600 and shift them over to the Community First Choice so that we could draw down that additional 6% federal match. That's, just to put it simply, that's one of the reasons why we're going after that. You're going to have, it's a person-centered support plan that needs to be developed, so it's similar to what we currently have within our 4 waivers, so that will be required. What's unique about Community First Choice is that there's a piece called Maintenance and Acquisition of Skills Training. So if there is the ability to make that happen with the recipient, of course we want to see it happen, where if they can do some of those activities on their own through the maintenance and acquisition of skills training, it reduces our costs, and that's a good thing. So that's important. Persons may choose to learn more, and in this bullet here, that really aligns with the bullet above. Persons may choose to learn more to be more independent in activities like bathing, cleaning their home, or shopping, and receiving training to foster independence. So that's important to note. And it says here, training for people to choose and manage their CFC/PCS assistance. It's similar to what we have currently under the PCS program with consumer direct and agency based. Under the consumer direct concept model, the recipient who is receiving those services will hire, fire, supervise, and train. So this is, it aligns well with the CFC. It's the same issue, same thing. And then what's unique to the CFC is that they, if this is something that can really enhance their independence or reduce the level of risk, is to implement emergency response systems. So if someone takes a fall, they have a device that they can push a button and then alert someone to the fact that they have fallen. So, and so what we'll do is kind of craft out and draft what some of those emergency response systems will look like for the state of Alaska. Okay. So, community first choice, CFC, PCS, person-centered support plan, maintenance, acquisition of skills training. We continue on down, emergency response system. At the very bottom, it says, please note the proposed services list may change, but what you see above, we felt it was important to note that. Now, if there's anybody online that comes from the senior world, they might think, well, why didn't you put in there supervision and queuing? Well, that is a part of that. So, and when this is all said and done with, when we implement and roll out the community first choice option, there will be a component. We'll have to put some restrictions around it, but there will be a component for supervision and queuing, in particular those individuals that have dementia. They may have the physical capabilities of getting from point A to point B, but they may need a little guidance and assistance in terms of how to get there. So I think that's important to know.
So this is Kara, just as a summary of this one. It includes the personal care services that we know about right now in PCS. It has a person-centered plan, person-centered support plan, which will be training and helping people understand what that is. It has this community first choice has in it maintenance and acquisition of skills training should the individual choose to learn to be more independent, and they will receive that training from their PCS CFC worker. And I'm kind of blending those together right now. They could choose to have training to select and manage their personal care assistant or CFC PCS assistant. They could choose an emergency response system. They do have the responsibility, the person served who has the responsibility to develop a backup plan. They don't have to do that alone, but they can put together a plan for help when the person that normally helps them doesn't come to work. And then, as you had mentioned, Dwayne, that supervision and queuing is on that list too. And so that's an example of how it might change, and also an example of how when the proposed regulation packet comes out, I think a lot of your questions and what you're thinking about will make more sense then, and you can form your feedback at that time too. Okay, so more facts about CFC include, you go back one, a person could choose both waiver and CFC.
Yeah, go ahead. I've been talking all week, so
okay.
I like the way you sound, and
okay.
You're smarter than I am, so.
I don't know about that, but it's all good. A person could choose both a waiver and CFC. Think about it, if the person meets level of care for a waiver,
right,
they could have a waiver. It could be that the person has one of the 4 waivers and choose CFC. And then that doesn't mean that services can duplicate or create, large services that aren't working for the person and don't create their life as they see it. Or it could. I mean, it could be that people need help, and that's what the plan of care looks like. So the plan is, if the person chooses to have only CFC and not a waiver,
right,
there will be a care coordinator, and they will develop the person-centered support plan, and that is called targeted case management. So it's care coordination, but it's called targeted case management. So it'll have different responsibilities and different duties and different pay. And those structures are still getting worked on. I'm not able to answer how much right now, but the Office of Rate Review is looking at what the duties are. And I see your questions about the rates and things like that. So I think, when we're done here, I'll be able to maybe put some shape around that. But, starting where we're at here, community first choice, most like PCS, enhanced PCS, including set services that are meant to help people be as independent as possible who meet level of care in the community.
And so with all of that, in the last two bullets here on this particular slide, we did hand out some one-page forms yesterday at the face-to-face Alaska Association on Developmental Disabilities fall meeting. One was on Community First Choice, the other on ISW. And so we did do that. And there was a document that talked about when we expect to put out the regulations for public comment. That's going to happen unless something blocks us or we're not ready. We're pretty certain that the draft regulations will go out for public comment. And so, as you know, when we do that, we also need to then seek tribal consulting, and that will happen in terms of its time frame. I think it's 60 days. And so we have that. And then we also need to then submit this to CMS and get approval. So with all of that, and I think in one of the slides at the end, we talk about a start date.
We
Maybe.
do have a timeline that I can show. I have a timeline document that we can show. A lot of this information has kind of been emerging from teams too. So that's great because we get fresh information from now and it's dynamic. So, okay. This is just our summary about what we talked about, and we'll, in just a minute, have it open to questions. I'll take a short, I'll freeze the screen and I'll go pick up that timeline document. It might help think of some more things we wanted to say right before questions, okay? So this will be, we talked about people needing help in Alaska and Alaska's budget. We talked about the intent of changes and being person-centered, creating real results for people, people driving their care, getting to decide what services will do, and strengths-based care, different plans to meet needs that the state, different approaches that the state is taking, and some new choices, at least starting with the ISW and CFC, and some new words to learn about the new programs. So I'm going to freeze on the screen, and I'm going to go ahead and catch the, pick up my other document, and we'll show that one. So just give me a second and we'll find that. In the meantime, think about your questions and we'll start answering those. So we'll be quiet here for just a second. Part of our webinars is sometimes a little bit of silence. It does happen. All right. My timeline graphic is what I'm looking for. Waiting for it to wake up so we can look at it. We're going to show this one.
So you can see it's a roadmap, and if you start from the bottom and you're driving along this blue road that turns into a purple road, we expect, given the level of work that we're doing, there are, as I mentioned, regulations that we put out for public comment. There's tribal consultation and then approvals from CMS. So that needs to occur. So much of that is going to happen over the next 3 or 4 months. We're making systems edits. We have a new program called Harmony that we're implementing within SDS, where we have to enhance that system to address the ISW and the CFC. So our target date to go live with the Community First Choice option and the Individualized Supports Waiver will be March of 2018. So many people are wondering when. There was a point where we were shooting for January, but the one thing we've learned a long time ago is that we're not going to blow this up and have some significant errors and mistakes. So if we have to extend and delay, then we do that. So March of 2018.
Okay, thanks, Dwayne. What I'm going to do now is I'm going to share again the PowerPoint, and I'm going to go ahead and show that. I'm going to freeze on that screen too. One of the biggest questions that I see coming up here is, can we get a copy of the PowerPoint? So what I'm going to do is I'm going to put it into the handouts section of the webinar, and it's one of the controls that you'll see up at the top of the screen. If your device is able to pick up PDF files and see them, you'll be able to see it. For example, some of our cell phones or smartphones, they don't have Adobe PDF Reader on them. If it's a fancy one, then it might, but you might not be able to pick it up if you're on a phone. Usually a computer can pick it up, but if you do not, if you are not able to pick it up, you can just write me a quick note and say that you would like me to email you one, and I'll do that. I'm happy to do that. It's pretty easy for me to do. Okay, so I'll prepare those and get them into our handout section. Some of the questions that have come in are about, let's see, questions about being person-centered. How can we make sure that the budget is used in a person-centered way if the person can't really advocate for themselves? Who's going to monitor that? Would it be the care coordinator and not the agency, or in a different way? What are your thoughts? My thoughts on that? Okay, I have lots of thoughts on that. Really, the best answer is that the purpose of introducing this is to help a person, and usually if a person, when people talk to me about people who can't advocate, it's really not that people can't advocate, it's that they have a representative. It's usually a legal rep or a parent or a guardian or somebody who's in place to advocate for them. That person is who you're going to work with. There is a care coordinator with that waiver, so it's expected that the person would have as much empowerment through their representative, if necessary, to direct how those dollars are used. So best answer is it's the person. If they need somebody to help, it's a person who's there, who's their champion, or perhaps a legal rep. It's not going to be, I wouldn't think about it as wholly, solely on the plate of a care coordinator or an agency. Care coordinators and agencies are going to have to talk, and they have to talk with the person, but whatever solution comes about needs to be of benefit to the person and at their direction.
And I think that to add to that, most of you obviously know that there was a day where there were two types of care coordinators, agency-based and independent. And now that we've made a shift away from agency-based, which I'm a fan of, the independent is truly responsible for the recipient in terms of meeting their needs, and doesn't have any secondary gain or motivation to really support the organization that they've worked for, the provider organization providing services. So I do think, I'm a firm believer that there may be some that will argue that there's a percent of people that are not going to be able to articulate what their needs are. But I think it depends on how you approach it. I think you can identify what those needs are for an individual that is nonverbal.
Yeah, I haven't met anybody who doesn't communicate ever. Okay, questions are, what does it take to be a provider for the waiver? My best answer to that would be that being a provider for these programs we're still working on that, and we're also working on rates and things like that. My best answer or window into it is that the intent is to keep the processes as same as they are now,
yes,
and to not add special certification, more work for you, more work for the senior and disability services. Just to do as much as we can to offer, if you will think of it this way, automatic approval. My other qualifier there, and it's an important one, is that for the individualized supports waiver, all of the providers who are approved to do that one have to be compliant with settings. Some of the services that are in that waiver are settings-based. So your movement and your emergence towards compliance with settings needs to be finished or otherwise conditionally approved should you be wanting to offer individualized supports waiver services.
Yeah, and that's important to note. We have time with our existing waivers in terms of settings compliance. March of 2019, I think, is the date. But if we are to implement any new authorities, we have to show that we are compliant at the moment we flip the switch on those new authorities, as in March of 2018. So that's important to know. Many of the grantees that are working for provider organizations in which they get grant dollars through the CDDG, the Community Developmental Disability Grant component, are already, they also have waivers within their world, so we'll honor that. But if it's somebody that's brand new and they're not affiliated with a organization that provides waiver services, they're going to have to go through the process of meeting those requirements through certification and compliance.
And I've put a couple of things into the Dropbox there, the handouts. There's 4. One of them is the PowerPoint and the presentation, I should say. The other one is one sheet on the individualized supports waiver and a one sheet on the community first choice, and then the timeline. Okay, further questions. Some questions about rates of reimbursement, particularly from the care coordinator. I know that when we were talking about the the individualized supports waiver, we were talking about the fact that it is based really just on those particular services, and that it is a smaller list, if you will, of services than what we're accustomed to looking at through the IDD waiver. And then in previous presentations, there was a lot of questions about that and kind of thinking about the IDD as the big and the ISW as the little, and really just want to encourage people to not think of them that way and just change your mind towards thinking about what the person needs, because that's the most important thing to think about first. So the duties of a care coordinator will be different, and it is not, when we say not as much or something like that, we don't mean that the rates are even decided yet, or that the rate for the same work would be different, because rates are decided on what the work is and what the cost of doing the business is in the area they're in. So if the work is the same, the rate's going to be commensurate. The amount of the units that a care coordinator must deliver of their service during the year, waiver plan year, or waiver ISW plan year, will look different. And it's quite likely that it will be not as many. But people will still have to have an annual plan of care, because that's kind of like a given, like that's right. What they always want to see. So it's quite likely that there will be less duties. And that is what we are saying when we say less, and not necessarily rates being less. And so that being said, we definitely honor what care coordinators do. We really appreciate that we've been able to have people reach out to you and work with these packets with you. We know that it's kind of cart before the horse, and I get a lot of questions about that. And it's okay. It's okay to ask those questions. But we definitely needed to, as Dwayne, you stated, to reach out and make this happen beforehand, because it would be too much to accomplish this after the fact. It's better to put out, I just kind of picture like a big net kind of scooping people who are interested. it's hard for us to know when people are receiving grants how many people are even interested in something, and we need to find that out ahead. And that is something that our care coordinators are in many cases helping us with. So thank you for that. It is not a situation where we're expecting people to do something, entirely without compensation at all. It's not that. It's just it's an effort, a team effort at this point.
Yeah. So great description or answer. We are working with the Office of Rate Review, where rates are established. We are, and so this is not something that we have tabled in terms of what rates will be for either target case management case managers or care coordinators under the ISW. It will be different, and we are communicating with the ICC, the Inclusive Community Choices Council, regarding that progress. So, March is, one might think that March is pretty far off, but it's right around the corner. So for us, we're working on this on a daily basis.
Absolutely. Some questions about the mechanism to bill. These are all things that you're going to be seeing come out in the proposed regs package. So look for that. Again, I'm not prepared to offer details of those things, but in Medicaid, you have to have a code that you bill to, and you have to be approved to provide that code. So those mechanisms are the ones that we know now. We're just going to use those to add these programs on, is my best answer right now. But those things are going to come out in our regs proposed things too. How is CFC different from PCA? It is different in the sense that it is for people who meet level of care, for nursing facility level of care, or any of the other levels of care that we had displayed, but we are intending it for folks who are meeting nursing facility level of care. They may or may not also have a waiver, but there are other services available in CFC that aren't in PCS, such as training for skills acquisition, training to select and manage your PCS CFC worker, supervision and queuing, and Lifeline, or not Lifeline, but personal emergency response system. And I'm looking at the question that says, isn't that Lifeline? And I'm reading that, yes, such as, but not limited to, Lifeline. So those are the big differences between the two.
If I could add, we have obviously wanted to, in our research with our contractors as well as the division, looking to other states that have rolled out the CFC. In the very beginning, when we first signed this contract, I think there were only 4 or 5 states, Montana being one of them, that had rolled out the CFC. Well, since that time to now, there's well over 10, I think 10 plus states that have rolled out the CFC. Within the Northwest, Washington and Oregon have done that for similar reasons in terms of what we're doing. And so we have met, we actually went to Washington to meet with our state counterparts in both states to talk about the CFC, among many other things, and just to get from them what are some things that we should not do that they did that they regret. So I share that with you. We've done quite a bit of outreach to try to minimize some of the challenges that we will have rolling it out. So
yes, it's something that a lot of states want to do because of a lot of us face a similar issue, and it's a helpful thing. Okay. Question says, since the ISW will not start until March, what happens if an agency runs out of DD grant funds, as they were all cut back for FY18? Okay, my best answer is that the DD grant ends in June, and when it comes to grant funds, an agency can deliver them as they propose in their grant and perhaps amend that, so it might be possible to redistribute your grant funds that you have received to make sure that somebody has the care or the support that they're getting from your agency through the grant. Next question says, why doesn't SDS bill tribal or Indian health for our beneficiaries getting waiver services and get 100% reimbursement?
Actually, that is the plan. So I could spend quite a bit of time talking about that, but that might be just a whole nother workshop just in terms of talking about that. In fact, now that you brought that up, whoever did do that, I think given what is happening right now with at the department level within the commissioner's office around tribal refinancing. So for those individuals that are native and they are tied to a particular region in the state and they need a particular service such as a waiver service that's not available within that particular region of the state, that the tribal organization doesn't provide those services, they go to a non-native entity that provides those services. In the past, or as it is right now, we can't claim 100%. But we were able to get agreement at the federal level through CMS, and did this about 2 years ago, that with agreements between the tribal organization and non-tribal organization, we're going to be able to claim 100% federal match, or 100% reimbursement, which is a good thing. We've done quite a bit already around transportation, and so we've realized through that effort, I think it's $35 million. So we have been very successful, and that's part of SB 74 of making that happen. So in due course, we're staggering this, and we're working on transportation. Now we're going to, I think it's residential psychiatric treatment centers, and then nursing homes, and then we'll move to the waivers. I know that the leaders within the DD world or the waiver world are anxious to be able to apply that rule, and anxious to establish agreements with our tribal partners, but we don't have the capacity to do a major flip of that switch. We have to stagger it so that we can manage it.
Okay, some of us are writing that you've gotten referrals for the ISW. What do I do with those? I think that your probably care coordinator is writing me that. Just assist the person to apply should they wish to do so. That's my best answer. There's a packet. It's a big packet. It has a lot of different pieces to it. Should the person wish to apply, then just assist them to do it. There's other ways that, at the end of the day, if the individual wants to apply and they fill it out themselves, or the family does themselves, we'll still accept it. It's okay. We're just trying to get the word out, and we're trying to learn more about people who want to apply. So best answer is just assist them to apply. If you get stuck on that, you could always email training. We'd be happy to help you and route questions and things like that too. Quite a few of us have asked about, will individuals currently on the wait list, the DD registry /wait list, lose their place on the wait list if they utilize the Individualized Supports Waiver? The answer to that is no. A person can choose to remain on the DD registry and for the IDD waiver, the one that you know about now, should they wish to do so, and they are using the Individualized Supports Waiver. The IDD waiver draw will continue as it is right now.
Well, and I would also just put out there, and that question came up from several individuals at the forum on Wednesday evening. So I think we did well to articulate that they can be on ISW receiving services, but maintain their status on the DD registry for the IDD waiver. So I think we provided assurances that will happen. Okay.
Part of the question also says, will individuals currently receiving PCS have a choice about if they want to utilize CFC instead, if they meet the criteria for that program? If a person currently has, or in the future, has nursing facility level of care, my best answer is yes. And that's what I'm taking that you mean the criteria. Somebody has PCS and they meet waiver or nursing facility level of care, and when CFC is available, they could choose it.
Let me just add to that.
Okay.
And just remember that we're moving fast and furious. So, sometimes the other day I inadvertently made a statement based on what we had talked about a month ago. Well, since then to now, there's been some changes, so I had to go on record to make a correction. So if an individual is currently receiving PCF services and they meet institutional level of care, therefore they would be able to access CFC, and you're asking, do they have a choice? I think we're at a point where these two programs are almost identical. We would be using the CFC to make sure that they got their ADLs or their IDLs, et cetera.
Okay.
So we do definitely want to understand that we're going after that because of the 6% federal match. And so I say this with the utmost respect, but let's be careful and let's understand where we're at, the realities of where we're at financially as a state. And so we're doing what we can to try to maximize federal return. So we had people on the CDDG grant that met eligibility for waiver, but because they were over income, they had very robust, expensive plans being funded through CDDG. They were expensive plans, but they didn't want to spend down and therefore be eligible for the IDD waiver. And you may not like this, but those days are over. We have to be able to stretch our dollars to serve as many people as possible. So we're not going to spend state dollars on a very expensive plan of up to $200,000, $250,000 when we can then capture Medicaid dollars. So I will stand by that.
Okay. So again, thinking about the person can have their needs met through PCS. PCS is kind of like within CFC. It's a smaller, it's like CFC is like a shell, and if I meet level of care,
right, assuming
I meet level of care, if I'm currently served by PCS, if I'm served with the same amount of services through CFC, there's no difference for me. And then I have choices of if I want to direct my staff and, if I want to have training to increase my independence and skills to care for myself at home, I could choose it. Those things I don't have to have. Those are options. They're optional within that program. But because of the reimbursed drawdowns, then people, those who are eligible will be served through CFC. But it won't mean a difference to them. It just means other choices that they could not choose if they didn't want them.
Yes.
Okay. A question says, does the state budget allow for behind-the-scenes workers like people processing applications and the Office of Public Advocacy and all the people that are other helping entities behind the scenes for people? Best answer is that yes. I mean, we work a lot with our program partners, and everybody's facing the same increase in populations that meet needs. So best answer is yes. Will grant funds be increased due to the delayed implementation date? My best answer to that is no. The grant, and it's just the CDDG block grant, the one that serves individuals with intellectual developmental disability through our grantees. It's important to note that our senior grants, like meals and things that have like the federal dollars coming in, those are not the ones that are ending. It's the CDDG block grant, the one that's been around for a long time. That is the one that is ending, and that is the one where we're hoping to serve people through the ISW should they choose it. Okay. I'll read it. I'm not sure if I understand it. It says, seems to be contradictory that the 1,600 CFC/PCS people who can be more independent meet level of care and receive fewer services than the other 2,400 who don't meet level of care. I'm not sure what that means.
Yeah, I don't.
If you want to write more, just reframe your question and write it in.
Please, thank you.
That would be good. Are there concerns that there might not be enough care coordinators to do the work with ISW coming on?
Yes, sure, absolutely. And we're doing what we can to attend to that, and reaching out to those associations tied to this world. Working with the Trust Training Cooperative and having interactions and conversations with them, increasing our capacity within SDS, within the training unit, to do more to provide training for care coordinators. There was a day, and I've said this all along, that training is an essential part to who we are as a division. So we've we've doubled the number of staff to be able to attend to the volume of training that we expect to happen going forward. So we do recognize that, there is an element of concern, but it's not as though we don't know that. We do know that, and so we're doing our best to attend to it.
Okay. Questions about what will this care coordinator job look like and what's the reimbursement? There's a lot of those. I just want to repeat that please stay tuned for regulations and proposed
Yes.
rates and things like that. It's really going to be able to answer these questions better. We've tried to put a little shape into those thoughts by saying, the same duties, it would stand to reason that rates would be the same for the same duties because of the different duties or frequency of them. There might be rates for other things that are not what you're accustomed to now. I know that we're all looking through this through the only window we have, which is today. And I'm the same way. I don't know these answers, but it's going to be, if it's different work, the work will be described and the rate will be described. If it's the same work, then probably the rate will be what you know now, because it's all found through cost surveys and things like that. So
much of that will be kind of scripted out and laid out within the draft regulations, and it really affords you a chance to offer your input. You may either like it or have a suggestion. And when I spoke to AADD yesterday, I had mentioned to them that the draft regulations will be out for both ISW and CFC this month, and there were quite a few that responded. Well, we know that our input is valued because in past regulatory packages, we have seen SDS accept some of the input that has come from our community. So it's just not an exercise that we go through. We actually do value what you say to us.
Okay. Okay. This question, I'm not sure if I know the right answer, but I'll read it out. If a person misses their 30-day deadline to respond to the ISW, I understand they are removed from the registry. Do they just need to complete a new R&R to be put back on the registry? My best answer to that is yes, but there might be details that I don't know.
That question came up, and so if that actually were to occur, and it probably will happen if it hasn't happened already, then you just need to reach out to that particular unit. We were at a face-to-face meeting with the Governance Council. I believe that question may have come up. And Maureen is a member, Maureen Harwood, who represents our division as the chief with oversight of the IDD unit. I think she responded by saying it's just as simple as reaching out to us, and we'll do what we can. We want to minimize this. Obviously, it's a very anxious and stressful time, so we're trying to do our best with what we have in terms of resources to reach out to families and recipients.
Okay. Couple comments about it says if you're already certified to do IDD services, you don't need additional certification for ISW. That's true, except that you still have to comply with settings.
Yes.
If you don't comply with settings, then that puts a stop on that.
Yeah.
It's a different story. But yes, the point is that we're not trying to put people through additional certifications or anything like that to be able to start doing those services and to bill. I mean, we have to get the billing codes and we have to get those structures done, but those that it's not different for the provider, I guess. If a person is chosen for ISW, what is the process to start ISW? Will they start before March 1st? I think what you're asking is a common question, is that a person gets a letter inviting them to apply. That means that they were on a grant, and they probably meet. It's thought that because they were in the system and DD eligible, that they should get this letter, and that what they're going to have to do is get the ICAP to determine that they would meet the same level of care as the IDD. It's an invitation to apply. It's not necessarily exactly the same thing as being drawn for the waiver. It's an invitation to apply. And so I guess my best answer about March is that the services wouldn't start before that, because, again, you have to have the billing stuff in place for a provider to be able to be reimbursed. So there's lots of moving parts.
Absolutely. Well said.
Okay. Questions about care coordination duties, again, commensurate with what it comes out to be. It's possible that this ISW, since it has less, a lower, or I guess a specific amount of services in it, that there might be a specific amount of care coordinator duties that are probably less than the care coordinator duties that are outlined for IDD. The duties might consist of the same work product being produced, like a plan of care. That's the best comparison I can have today right now.
And just remember the cap of 17.5. So, and then your plan is developed based on what you can accomplish within that 17.5.
Right.
So it's probable that there will be a significant difference, and it's probable that because the work is not as intense in terms of what you do within the IDD waiver, that the size of that caseload would be different as well.
Right. All those things impact doing the work and expectations of the work product and the service. Okay. A couple of these we've already answered. I'm looking. When I'm quiet like that, it just means I'm looking. If a client is pulled for the new waiver, and again, what I'd like you to think about it is, if the person is offered the chance to apply, when that waiver comes about, yes, they must have a care coordinator. We are hoping and encouraging care coordinators to help a person fill out that packet to apply. But yes, when they have that waiver, they will need to have a care coordinator. There's lots of concerns about being limited in care coordination professionals in our rural community on our comments here. So our point, we get it. We understood, Dwayne had talked about care coordinators, and we're always hoping to increase our number of professionals and do what we can to support them. Really, some of these answers only come with making these initial efforts that we're doing now. We don't really know any other way to get to the future except to start now. Okay. We appreciate your help on any level with that, honestly. I mean, I feel like we work pretty well, training works pretty well with a care coordinator team. So if you have ideas about how to help care coordination in the rural community better, I definitely welcome them and would wish to do that. Okay. Could you walk us through an example of how these two programs would benefit a senior, for example, who has ADRD, who is not currently served by existing funding programs?
Well, let's just talk about what we currently have. We have the last one's living independently waiver. And when we look at the data, a significant percentage of individuals that are currently receiving services through that waiver, I think it's at about 2,000, are primarily seniors that meet institutional level care, NFLOC. So we have that. We have roughly, of the 40 million, there's about 16 to 17 million in senior and community-based grants. So, senior meals, congregate meals, home-delivered meals, transportation, case management services, adult day services, family caregiver support. So we have that. The CFC is for those individuals that have a developmental disability, and we are an aging state, so we're seeing, I have actually been into adult day centers and have seen seniors with developmental disabilities in these adult day centers. So that's starting to happen in Alaska. We have 13 adult day centers throughout the state. Capacity, although we're at capacity, so we know that there's a demand there to support families who are caring for their elders who need to be in adult day center during the day so they can go to work. So we know we have that. The CFC really is a key component to serving our senior population. So I've been talking with the Commission on Aging, and I think the big piece that they appreciate what this brings. We talked about some of the unique differences between the PCS program, in which we have a significant percentage of people that we serve that are seniors. So then having the CFC is just an addition to that. And the supervision and queuing piece is really going to help. In saying all of that, I know that we're going to have to do more beyond even what we've just talked about to be able to meet the demands of the senior population. So last year, I spent a lot of time in the halls of the Capitol, really having a lot of one-on-one conversations. I believe that it's a bipartisan support to really value what we have in place going forward for our senior population. Whether you're a Republican or a Democrat, both understand that we have to have that structure and that capacity. And so I have told people that if there's one thing that keeps me awake at night, it's how do we serve our senior population 5 to 10 years from now? So I think we need to do more. So that definitely is, in my book, number one on my list of what we need to do.
Okay. Lots and lots of questions. By the way, if we don't get to your question in this time, don't worry, because we can create a report of your questions. If I skip your question, it just means that it was already answered in another format, or there were a bunch of people who had the same question. Today is not the only time that you have to engage about this topic. You can certainly email our training inbox. It's sdstraining@alaska.gov if you want to comment or provide feedback regarding this session. If you're like me, you might think of something tomorrow that you wanted to ask. You can always ask it. We'll do our best to compile questions and answers and get answers out there, and it helps us to know what those questions are. So, just give us your questions and know that we're recording them and developing ways to collect that information and get information out. It's part of our communication plan. Okay, will the current waivers stay in place, or are they going away and new programs coming online?
That's an excellent question, and thank you for that, because that has come up time and time again. So I appreciate you getting that on to the screen. There is some fear that by bringing in the ISW and the CFC, that we're doing this with the intent to eliminate the existing personal care services program, or to do something in which we reduce and or eliminate the IDD waiver. And my response is no. This does not replace anything. Just remember this, and this is the important piece. We're refinancing general fund programs so that we can attend to the budget crisis by bringing in additional federal dollars. So refinancing CDBG is a key component of that. So nothing, our existing structure, our existing programs are not going away. They're staying intact.
Okay. Do targeted case managers have to be conflict-free like a care coordinator?
Yes.
I think my understanding of it is that it is a care coordinator. I don't know that it's a brand new service. Like if there's not a brand new person that's going to get certified just to do that, it's a care coordinator.
Right.
The service is targeted case management.
Yeah. Thank you for that. for those individuals that meet institutional level care, are on CFC, and are not tied to the waiver, we're using targeted case management as that vehicle. You know, maybe it was me that said the other case managers, but really, Kara is right. It's all one. Yeah, we're all care coordinators doing what we can.
Yeah, and I'm learning too. I mean, it's new to me. It'll continue to be new. Even our existing programs sometimes seem new. Okay. Question is about, we talked about people with IDD having the ISW. We talked about different populations and that we were not going to implement 1915I, and we talked about that helping people might have or may have assisted people with traumatic and acquired brain injury, ADRD, IDD, and SMI, severe mental illness. What will be done to help these populations in the future, now that we've mentioned ISW and CFC? So what about traumatic and acquired brain injury, ADRD, and SMI population?
So of the 4 populations that we identified to consider through the 1959, we are now replacing the ISW for the I specific to the IDD population. So I think we're good there, and that's pretty much been the bulk of our discussion today. There has been, and this is all very preliminary, but we want to go back and revisit. And I just want to remind you that for us, as it is for you, it's all about capacity. But with our current contractor, we believe we need to go back and revisit the 1959 to address our ADRD population. So we have created a preliminary draft position paper. We have communicated with the ICC specific to that, but we're having to table that because we have some deadlines that we have to hit, as in March of 2018. Mm-hmm. The traumatic brain injury population, you know, if there are other disability issues on top of that that qualify them for what we have now within our existing waiver structure, and they meet eligibility, we are attending to that. We have been working closely with the Alaska Brain Injury Network about our ability to do more, to have concrete data that will help us in our advocacy efforts, in our educational efforts going forward. And we agree that targeted case management is a starting point, right, to make that happen. That said, we've had to put that on the parking lot list until we, you know, roll out the ISW and the CFC come March of 2018. Right. The SMI, severe mental illness population, behavioral health is doing a massive Medicaid reform effort around the 1115 demonstration waiver. So much of what we're doing right now, much of what we're talking to you is happening over in the behavioral health. They're not as far along as we are, but the 1115 is the vehicle that we will use to address our SMI population.
Right. Okay. Question about staffing as it relates to service delivery. Concerns about how the new waiver will impact service provider agencies' ability to actually provide services. The question mentions a lack of staffing for people who have the IDD waiver. The question is, does the federal match only happen if services are provided? Yes, it only happens if they're provided. It's not, Medicaid is a fee-for-service situation. It's not like money that you get ahead. You have to do the work and then get reimbursed. And then there's all the rules that are involved with that small trajectory I just listed. Knowing that, it's possible for a provider agency to take a look at how many people, you know, are applying and how many people get involved in this ISW waiver. The factors that they might already know are people who are already on grants and the services that they're getting on grants. When the regs come out about the rate of reimbursement, they can look at the rate of reimbursement. They could look at the rate of the service that they actually provided to the person on grant, and they can try to develop a plan to try to meet needs and close that billing loop. They can interview families. They can, meet with people to actually participate in their plans and develop ways that work for staffing. So there's lots of information that is known. I know we're talking about a lot of unknowns, but they didn't come out of nowhere. There's a lot of data and information available to those who are already doing the grant services to think about how this might be worked, how it might work for them. Okay. This is a really good question. I'm not sure I know the answer. If someone has a general relief that's paying for them to be in an assisted living home and they get the packet for ISW, but it doesn't cover residential, would the person be able to access both general relief and ISW services? I'm not sure.
Oh, boy, that's a great question.
Might have to call an expert on that.
Yeah, phone a friend, or not actually phone a friend, but now that's a really excellent question. So if we're not covering residential through ISW, could we use general relief if they meet eligibility, obviously, for general relief? Well, ISW requires institutional level care. You have to remember that. Could you do a mix of the two of them? We don't know. Now, I got to remind you that general relief, that budget has taken a hit the last couple of years. So what was once a budget of close to $9 million several years ago is now down to about $7.3 million. And we're feeling the demands from hospitals who are making referrals out of their discharge centers, from corrections who have individuals that would meet eligibility for GR or for waiver coming out of DOC, wanting to access GR. So we have had to we haven't implemented it yet, but it's there just in case, a wait list for general relief. So being fully transparent, there are some challenges for us with that, with the general relief budget. So we're working very closely with the Alaska State Hospital Nursing Home Association to identify what we can do to stretch those dollars, as well as give them a platform in terms of what they need to do to advocate for more dollars going into the future. So I love the question, and now you got us both here pondering.
That's a good question.
Yeah, excellent question.
Okay. Again, lots of questions about how to become certified or how to enroll. We're hoping to make the process as streamlined as possible and to do it automatically as much as possible, as long as the provider complies with settings and as long as the provider is in good standing with their current certification for PCS, for CFC, or the waiver services under IDD waiver for ISW. Okay, how can a person be a part of the ICCP group or ICCOS? Are they still open to have people join them, or is that nobody else can join?
Well, that's been established and has been. When we have we have a charter that kind of gives us the ability to address maybe a member who has missed the last 3 or 4 ICC meetings, and if that's the case, then we will then reach out to that member and ask, why have you missed? And it may be a medical reason or a personal reason, so that we have replaced those individuals. Our membership is full. We have 11 members on the ICC, and then I think we have 8 or 9 advisory associations that are on that as well. But it is open to the public. And so on our website, if you go there, there's a link right there. It should just hit you right in the face on our reform efforts. If you hit that, you're going to see a series of monthly minutes, agendas, PowerPoints, all the forums that we have held to gather input. All of that information is there. When we announce the ICC, it is open for the public to come and be at least in the room to observe. They're not to really be a part of the discussions, because that we leave to the members of the ICC. So we have had people show up and sit in the back to observe and watch.
Okay. Good to know. We're coming up on 10 minutes till the end here, so I'll probably just kind of move fast, and then if you want to add, just tell me. We'll get there. We still keep getting questions, so thank you. Thanks everybody for sending your questions. Okay. What about people who stayed on the DDRR, the DD registry? They have the ISW waiver and they stayed on the registries. Do they still need to update that DDRR based on changes in condition? My best answer is yes. Traditionally, we teach, generally we teach that the STAR professionals will do that. They'll help a person, give updated info onto that DDRR. So I don't see that there would be a change in that.
So let me just add this, because I think it's important for you. No one has asked this question yet, but so many of the individuals that are currently on the DDRR who meet eligibility for the ISW will then receive services within that area. So the wait list will drop significantly. Now, granted, going forward, anybody that gets onto applies for will then be added to the registry, but it's going to do a significant reduction to that. So that's important to know. There have been people, for example, some of the board members for the Governor's Council on Disabilities and Special Education has said, well, we know that there's going to be some people that do not meet the ISW eligibility requirement. And my response is that's correct. So then their question is, so what are you going to do about those individuals if all those grant dollars go away by the end of June of 2018? So we, based on what we have pulled, application has gone out. We've done about 220. We believe there will be a small percent of individuals that will not meet ISW eligibility. So we have set aside about $500,000 to attend to those that don't meet eligibility and want to continue receiving grant services. So that said, that doesn't mean that any new, the grant services, if they over time do meet eligibility, they will shift to the ISW. But anybody new that's coming in will not receive grant dollars. So that's just kind of the reality where we're at right now today. Okay.
Question about clients with PCA services or PCS currently who meet nursing facility level of care. And the question is that CFC wouldn't support the level of service they currently have through PCA, limited at $17,500 per year. I just want to emphasize that it's only ISW that has that limit. CFC is related to their approved service level authorization, which comes through the person's assessment. And then if they choose to get the skill building service, they could get that, or their training in how to manage staff. It's possible that that would be, that could be added on. But again, the essence of it is that CFC is not under that limit. The ISW is. I know we looked at them together. So
there is a cap. There is a cap of 17.5 to ISW. There is no cap within the CFC. There are some unique things about the CFC that's different from personal care. When we talked to the state of Montana officials, we had a very extensive conversation with them, several, as well as the state of Washington, Oregon. We talked about this very issue. No one's going to be reduced switching from the PCS program to CFC. So I just want to be clear with that.
Okay. Question says, where are all the people who get moved out of nursing facilities going to live? Just to be clear that we're talking about different options for community, home and community, or long-term services and supports, rather than moving people out of nursing facility. If a person is in a nursing facility and they're still meeting level of care for that nursing facility, they have Medicaid, if they need to stay, as determined by their care team, they'll stay. If they wish to live in the community with supports, then these are the supports we're talking about that could be amongst their choices. Most people, generally want to live in the community at home where they can get their care.
And I think that I appreciate this coming up because I do think as a state, when I spent time talking to my counterpart in Oregon several weeks ago, I spent several days with them. They have a very robust transition, nursing, I'm not sure what they titled it now, but it's transitioning people out of nursing homes back into the community. I think that we need to kind of step back from what we have been doing, and so that's come out in conversation internally, as well as conversations with some of our key partners, that I think we need to do more to provide that as a true option. So I think just stay tuned to hopefully something coming out, again, specific to that. Now remember, again, capacity. Do we have the capacity to do all that today? So there are a few things that we are putting on the parking list of things to attend to down the road.
Yeah. Good question, though. Okay. More thoughts about the care coordinator doing targeted case management. The plan, the person-centered support plan that they would create for somebody who has only CFC and not a waiver. If you think about it, if your PCS agency is enrolled and certified to provide CFC, which is the plan, PCS hasn't had a care coordinator, but care coordinators have worked plenty around working through PCS services with a person's PCS agency, and they have waiver as well, people who have both. So they're going to be making a plan of care, and what the requirements of those things are and how they work together with the PCS agency and their admin are all things that will be evident in our proposed regulation. So stay tuned for those things, but I'm glad that you're thinking about them. Question says, if the person is invited to apply, but then for the ISW and then they don't apply, they can remain on the registry. That is true. If they remain on the registry and their score doesn't change, will they be invited to apply again during the next invitation round? My best sense of that is that it really depends on how many people end up using the ISW and lots of other factors. As a very preliminary entry decision point, the maximum that the ISW, where there were 600 people using grants. So the thought is that there are 600 possible ISW users. Of those, we don't know how many are going to actually go through the process to apply and meet level of care and get those services. So that's the framework that this question comes under. It's really not possible to answer it right now today. It's likely, because I'm not sure that every single person who gets the packet will fully go through all that. But it's possible. It would be up to them should they apply now or later, but it's possible. What should a family do if they cannot find a care coordinator to help them with their ISW application? And then it says, or plan of care. They will not be able to create their own plan of care if they want to apply for the ISW. They can, worst comes to worst, they can fill out the packet on their own. If they had to, they could. We would take that packet. We would gladly accept that if they could not find a care coordinator to help. Families can ask other knowledgeable folks for help too, not just a care coordinator. It's really not just about only a care coordinator doing that, although we greatly appreciate their assistance because it makes it so much easier for the families. Okay. We're coming up to the end here. We're just about 3 minutes till the end of our session. I'm just going to go to the bottom and see see the different questions and comments and things like that. Okay. Okay, lots and lots of questions. I think that probably what we should do is just get as far as we can where we were. People who are selected to apply, they can have somebody help them with the application packet. Yes, the letter says the first step is to find a care coordinator. They can, if they cannot find a care, we wish that they should find a care coordinator, and we're directing people to find a care coordinator. But they can apply, and if they have missed that 30-day mark, then my best understanding of it is that that's their deadline. They would have to wait and then to stay on that registry and apply should they be selected again.
Let's take one
more. Okay, one more. Let's find a different one here. Some of them are off topic too. We're still here, we're looking. Okay, still looking here. Some of them are duplicated and some of them are just comments.
Well, let's do this. As Kara said, once we close this out, we will look at the remaining questions and then we'll respond to that, and then we'll have a record of that for people to be able to access.
Yeah.
So in summary, good questions. I really appreciate that. So it's 159.
That might be the last one.
The last one.
But
let's
eligibility for CFC. Who would be eligible for CFC?
Who would be eligible? Those individuals that meet NFLC or institutional level of care. So we mentioned that before, but that is the eligibility. It's similar to what we have currently with our 4 waivers. So that would be the
best, quickest answer.
Yeah. So as you heard from me, we're coming up on just months away from March of 2018 when we project that we'll go live with these two, the option of 1915K and the authority of 1915C, the ISW. There's a special session that's going to kick in here this month, but the actual session starts obviously the 3rd week of January. We'll do our due diligence and provide updates to the progress that we made around the reform efforts, and do a lot to really educate the legislature on the importance and value of these programs and services that we have within SDS. And of course, all of you, because it's a state where we all are vested in what we do in terms of LTSS, I would ask that you do your part as well. And the more that are engaged and involved in helping to educate the legislature the value of what we do, I think we can get through this next session with hopefully minimal damage.
Okay.
So with that, I thank you we had a great turnout of 200 plus people, and I had somebody tell me that many of the folks who have signed up did so with the understanding that in their conference rooms it would have 10, 15, 20 people. So I know there were much more. So we feel very good about the impact in terms of our audience. So thank you for that. So I wish you a great weekend. Have fun out there.
Thanks, everybody, for being a part of our webinar and choosing to spend your afternoon with us here. Thank you so much. I will leave our comment area open in case you have any last questions that you want to put up there. We'll have our audio turned off, though, so we won't be answering them by audio. And just stay tuned for more compendiums and collections of answers and the recording of the session. So thanks, everybody. Goodbye for now, and